So I altered what I was going to talk about this evening. Originally I was going to talk about some zoonotic infections that are of interest to me, plague and tularemia, but because of all the current interest in Zika virus and other arboviruses, that's what I will address tonight. And I brought way too many slides, but we will be able to at least get through Zika virus this evening. But first I'd like to go through some definitions from established infections to emerging infections and then re-emerging infections. So established infections are those that are no surprise, they are viral and bacterial, respiratory, and diarrheal diseases that we have pretty much more or less adjusted to with expected morbidity and expected mortality, as well as drug-susceptible malaria, drug-susceptible tuberculosis, and nosocomial infections. Emerging infections are those that really haven't appeared in humans before, like when HIV infection appeared in the early 80s, or Nipah virus, or severe acute respiratory syndrome that appeared in the early 90s. And then re-emerging infections are what I will talk about this evening, those that have been known to infect humans, but they have altered their geographic reach, including Zika. So those are the ground rules of this evening. And I wanted to reinforce emerging and re-emerging infections with this slide, a couple of other infections that newly appeared in the population that I won't go into great detail on MERS, Middle East respiratory syndrome, and then H1N1 influenza when it caused the most recent influenza pandemic in 2009, had not really been in the population before. And then a more expansive list of those that are rapidly increasing in incidence or geographic range include Ebola and cholera, hantavirus, polio in Africa, enterovirus D68, and then, as I mentioned, plague, tularemia, and also Legionella. But tonight we're going to focus on Zika, chikungunya, dengue, and West Nile virus. Now, all of these are arboviruses, which means that they have mosquito vectors. Zika, chikungunya, and West Nile virus are all flaviviruses. I'm sorry, Zika, dengue, and West Nile and chikungunya is an alpha virus. And then the other virus that's related to them, unfortunately, we don't see because of appropriate vaccination is yellow fever, which also is a flavivirus related to Zika, dengue, and West Nile. And because we have vaccines for yellow fever and another flavivirus that's an arbovirus related to 3 out of these 4, Japanese encephalitis, perhaps we'll have a leg up on developing a vaccine for Zika virus. So this story, even though it's a current news item, really goes back thousands of years. So Aedes mosquito-borne arboviruses relate to vector adaptation to human adaptation. So when warming and drying occurred in North Africa 5,000 years ago, it forced ancestral arboreal mosquitoes to adapt to new environments in which humans were storing water. So when there was plenty of water around, they didn't have to seek out water in human habitats. But when water was scarce, they went to where the water was, which was where humans were living. And that's what we refer to as water-based. Mosquitoes need water to flourish. If there's no water, there's no mosquitoes, and if there's no mosquitoes, there are no arboviruses that are borne by mosquitoes. So this led to new breeding sites. Mosquitoes, instead of breeding in the forest away from humans, would breed in stored water containers where humans lived, closely tied to their habitation in which case the viruses would adapt to, instead of infecting monkeys in the forest, would infect humans because that's where the vectors were. And that's really the basis for all four viruses that I wanted to talk about tonight: Zika, dengue, chikungunya, and West Nile virus. The other thing about West Nile virus, because I'm not going to be able to get to that one, the mosquito vector is different. It's a Culex mosquito. So, focusing on Zika virus, it's a single-stranded RNA flavivirus related to, as I mentioned, dengue, yellow fever, Japanese encephalitis, and West Nile viruses. The symptoms include fever and headache, rash, malaise, just feeling bad, arthralgia, myalgia, and conjunctivitis or pink eye. Typically milder than dengue, milder than chikungunya. Severe disease is rare, but there are complications, as you know, and I'll get into that. And as I mentioned, it's mosquito-borne, but there are other forms of transmission that make it a little different and a little more complicated than its relatives. And we're learning more about that. So these two maps of the U.S. relate to the expansion of the Aedes aegypti mosquito and the Aedes albopictus mosquito. So albopictus, as you see, goes a little bit farther north, all the way to New York City. Now, this is an Aedes mosquito. It carries some of the other viruses. We don't know if it will be an effective vector for Zika yet. This one we know is an effective vector, the Aedes aegypti mosquito, and that is focused, as you can see, around the Gulf Coast, Texas, Louisiana, and Florida. So there is an appropriate vector for Zika virus in this country, and perhaps two, we'll see. There's also vertical transmission of virus from mother to baby during pregnancy, and that has very grim consequences with microcephaly and other complications related to pregnancy. And then it can also be transmitted through blood or sexual contact, and we're learning more about that. It's a previously relatively unknown flavivirus, as I mentioned, originally discovered in 1947 in the Zika forest in Uganda, where a rhesus monkey developed the infection, and then subsequently reported only sporadically in humans from 1951 to 1981 via serologic evidence. So antibodies were identified in people who had been previously infected with Zika in multiple African countries and parts of Asia. A large outbreak was identified outside of Africa and Asia in Micronesia in 2007. And it again featured a relatively mild illness with fever, rash, arthralgia, conjunctivitis, with subsequent spread, and this is important, to French Polynesia in 2013. There, more severe illness with neurologic and autoimmune complications were identified. Specifically Guillain-Barré syndrome, which, as many of you know, is a post-infectious, autoimmune, acute, inflammatory, demyelinating polyneuropathy. So essentially, the covering of peripheral nerves is destroyed. Patients have paralysis. It's ascending from lower extremities to the trunk. Most of the time, patients do okay with appropriate support. And sometimes other interventions. But if the diaphragm is involved and is respiratory depression, there can be fatal outcomes. And again, there's more that we need to know about the association of Zika with Guillain-Barré. And this is apart from pregnant women. This would be anybody. In 2014, there was a localized autochthonous transmission with spread, first reported in Chile. And we talk about autochthonous infections all the time in medical geography, and essentially what that is that an infected individual came to Easter Island, which is part of Chile, as you know, in the Pacific Ocean, and was bitten by an appropriate Aedes aegypti mosquito. The mosquito became infected and then bit an unsuspecting, uninfected inhabitant of Easter Island, and then the virus spread from there. And so that is believed to be how Zika virus arrived in the Western Hemisphere, specifically the Americas, probably because of the lineage of Polynesians from Polynesia and who inhabit Easter Island. And every year there is a festival that attracts Polynesians to Easter Island, and it's believed that's how the virus arrived in this hemisphere. In 2015, Brazil confirmed indigenous transmission was spread within the country, and they may have had maybe 1 million cases of Zika virus. And it's believed that possibly competitors in the 2014 World Cup who were infected with Zika virus brought it to Brazil, and then transmission evolved from there. In late 2015, a 20-fold increase in cases of newborns with microcephaly linked to maternal Zika infection during pregnancy was reported. And microcephaly is not very common in any country, but there was a 20-fold increase there. And microcephaly is defined as a head circumference in a baby of less than the 3rd percentile. And of course, if the head isn't very big, then that means there's some small brain as well. With further case reports that are now being published, it's really more than just microcephaly. Placental insufficiency has been reported, calcifications in the brain, as well as intrauterine growth retardation. So the fetus is, as well as fetal loss. So there may be devastating consequences to the fetus when a mom is infected during pregnancy. And we don't know if it's only if mom is symptomatic with infection, or if asymptomatic maternal infection will result in fetal compromise. We don't know that yet. And affected fetuses at all levels of gestation have been reported. So we don't know when the most devastating time for the infection is, although it's believed it's early trimester. Even moms infected in 2nd and 3rd trimesters have delivered babies who've been infected. So after Brazil, there was spread, and no surprise, throughout Central and South America. And then the first confirmed case of local infection in Puerto Rico was identified in December of 15. So there's not a long history here, and so the story is evolving. So most days we learn something new about Zika. The first U.S. case of microcephaly due to Zika was reported in Hawaii in January of this year. Mother was likely infected in Brazil. No autochthonous transmission reported in U.S. to date. So far, no infected traveler has come back to the U.S., been bitten by a mosquito who acquired the infection and then bit an uninfected inhabitant of the U.S. That's possible, but it hasn't happened yet. This map just shows us the extent of Zika virus as we know it now globally. So the dark purple are areas where Zika has been identified or isolated, and the stippled areas are results of serologic surveys where antibodies have been identified in inhabitants of those countries. So it's pretty widespread and would fulfill the definition of a pandemic. And this is just a close-up of the epidemiology of Zika to date in the Americas. So 80% of infections are asymptomatic. The incubation period is 2 to 7 days. The duration of illness is a few days to a week, so not very long. Diagnosis is either by PCR, molecular diagnosis to identify the virus itself, less than 4 days of illness, and then after 4 days, if we can pick up antibodies through IgM testing. The problem with picking up antibodies is that they're cross-reacting bodies to other flaviviruses like dengue, which is also endemic in the Americas, especially in Brazil. So the best way to make the diagnosis is by molecular assay. And then care is supportive. We have no antivirals, and we have no vaccine. So the best way to prevent Zika is to prevent mosquito bites. These Aedes species mosquitoes bite during the day, so it's not easy to prevent. But the measures that prevent Zika would also prevent dengue and chikungunya. Because there is sexual transmission, protected sex, safe sex, or abstinence has been recommended for pregnant women whose partners have traveled to Zika endemic countries. So far, only sexual transmission has been documented in males who have been symptomatic, but we don't know if asymptomatic men can also transmit the infection to their partners. There's been no identified cases of sexual transmission from women to men, but more studies are indicated. In terms of safe sex for non-pregnant women, for partners who have either been infected with Zika or traveled to endemic Zika areas, the CDC recommends discussion but doesn't say about any time limit. Certainly the time of pregnancy would be a time to avoid unprotected sex in someone who could possibly be infected with Zika. Blood donation to protect the blood supply. The FDA has guidelines on donors, and they're complicated in terms of if they've traveled to a Zika area or if they've been infected, and the same goes for transplantation of organs guidelines. So the FDA, the CDC have been very good about providing timely guidance in protecting the population with the knowledge that we currently have. But again, more studies are indicated. And I think that's my 20 minutes. And when we get to the question and answer period, the panel discussion, I'm happy to talk about other arboviruses in the Western Hemisphere, including chikungunya, dengue, and West Nile virus. Really, thanks so much.
I'm Bob McNally. I'm a graduate from 1970 College of Electrical Engineering, and then went off to University of Pennsylvania to finish up a PhD in biomedical engineering. And now in kind of the twilight of my career, I find myself doing one of the hardest things that I've ever done in life. I've started companies where we've transplanted human valves, arteries, veins, all the components of the human knee. And that was simple compared to trying to construct a vaccine. And I have to give a lot of credit to Bob for it was a nice background on Zika. You know, all the things that we read, those of us that are in the world of vaccines, we read a lot of things. But Bob did a really nice job of making it nice and concise for you. And it kind of puts the fear of God in me because I live in Atlanta, and that's kind of the bullseye for the Aedes mosquito. And I've killed a few of those in my backyard, so I know that they're there. So we're going to spend a few minutes. We're talking about vaccines. We have a pipeline of vaccines that GeoVax has been working on. We're a biotech. We're a development company. So we have a couple handfuls of scientists that are working on those really hard vaccines that are for unmet needs. And these are mostly global issues. First of which is why the company was formed, and that is to do an HIV vaccine. You know, HIV has been around for 35 years or more. It's the 6th largest killer around the globe. In the US, we have 1.2 million people that are infected with HIV. Most of you think HIV is a thing of the past. Well, it's not. And let me give you the sobering statistics on HIV. The fastest growing demographic is in the 13 to 24-year-old age group. So look around you, folks. This is the age group that's growing roughly at a rate of 10% per year. So HIV is not going away, and there is no vaccine for it. And so we're developing one. We have one that's ready to go to efficacy trial. That means that it's been in roughly 500 individuals. And efficacy means we want to put it in a population of individuals that would be at risk for coming down with the disease. That's called a phase 2B program. And that's only roughly 2/3 of the way in vaccine development. We've been doing this for 15 years and still don't have the vaccine out the door. Patents run out pretty soon. Good thing the FDA gives us, because it's a biologic, gives us an extra 12 years to get those vaccines out the door. And we also do one for Clade C, which is the version for Africa and Southeast Asia. So HIV has major subgroups around the world. Clade B is the one that we have in our backyard. That's North America and Western Europe. Clade C is the other parts of the world. And we also have in development Ebola vaccine. And we also have a tetravalent version of this, which means, it's a big word for meaning that we also put with Ebola the other hemorrhagic fevers. So we put Marburg disease, Lassa fever with it, and I'll explain to you in a minute how we make those. And because of the way that we make our vaccines to stimulate the immune system, it's one of the things that Bob didn't necessarily bring out in his introduction, but the whole purpose of a vaccine is so that your body does the work. We want to stimulate antibody and T cells, your white cells, in order to be able to fight off infectious diseases. And it's how well you train the body to do that through your vaccines that makes a difference. And you can also do it for oncology. And so this is the big wave of the future. Everybody's talking about this, immuno-oncology in the world of biotech. And of course, we have a Zika vaccine up here as well. So let me tell you how the magic sauce, as it were, for trying to make a vaccine. We use a smallpox vector. It's called modified vaccinia ankara. And in that vector, we take some of the antigens, in this case from HIV. And up on top here, you'll see what an HIV virus looks like, all blown up. And on the surface of this are what are called glycoproteins. This is what the virus uses to attach itself and infect other cells. And so what you want to do is you want to develop a way so that when this presents itself, your antibodies are going to attack it. Just glom onto it like glue. And then also you have T cells that will see the antibodies like a flag sitting there. T cells come along and try to destroy it. So that's the theory behind how it's supposed to work. And obviously it doesn't always work that way, because those of you who've had your flu vaccines know that one year may be good, another year may not be good. So what we do with our vaccines is we make what are called virus-like particles. So we put in this smallpox vector, the genetic material, to train it to create these small spheres, but in particular on the surface of those spheres, we want those glycoproteins to be present. It's non-infectious, it's not going to hurt anybody, there's not even any adverse events, but the whole idea is that the better you train it to look like the real thing, then the better off you are to have a very effective vaccine. And so what you see here is a cartoon. Here's these glycoproteins, these are antibodies, and those antibodies can also act like flags so that when it sees the real virus, it can be destroyed. So this is what it looks like when you give somebody an injection. This is a cell that's been exposed to our vaccine, and budding out of this cell are these small microscopic spheres. And if you could look on the surface of those, you'd see those protrusions, those glycoproteins, but they're microscopic. Of course, you don't see it. So that's the theory behind how we do it for HIV. But Ebola is a different structure. Ebola is a long, stranded, like a cliff note in music. This is what an Ebola, this is the same thing. Here's a cell that's been exposed to our vaccine, and budding out of this cell are these long strands, and on the surface, those of you who are lucky enough to sit up front can see these small glycoproteins. And so that's why we think our Ebola vaccine is going to be better than some of the competition. Now we're going to talk about some of the sobering factoids of HIV. We mentioned there's roughly 34 million people globally, but in the US, where we have between 1.2 and 1.4 million, this number of 50,000 new infections has not changed in 20 years. Now, you may not read about it in the newspapers, and it's not big news anymore, but it hasn't gone away. So all the effort that the U.S. government and healthcare workers put into trying to educate people, safe practices, take their meds if they're HIV infected, can only get that number down to a certain point. And what's going to make the difference? It's going to be vaccines. That's really the bottom line. You're going to need a vaccine to make a difference. And here's the other sobering part, and this is put out by the CDC. When you start off with 1.2 million people, give or take, because you don't know everybody that happens to be infected, some of them are diagnosed, some are linked to care, some actually take some of their meds some of the time, but only 25% take their meds all the time. So what does this mean? It means the other 75% that are in here are still spreading HIV. Again, even though we have medications, the U.S. government spends $17 billion a year giving away meds to people that are HIV infected. You can't get people to take them or take them on a regular basis, and we're still spreading the disease. And here's this fact I was mentioning to you before, the 10% growth rate in the 13 to 24-year-old age group. And I think a lot of that's because HIV is not big press anymore. People think it's a chronic disease, nothing to worry about. And so it's the younger population that really is at risk. Here's some of our primate data. This is how we do it. We have a control group that don't get the vaccine, and then we have a vaccinated group. HIV is such a difficult virus to harness that it actually takes 4 injections. It's a little bit like some of the hepatitis injections that you might get. And so these monkeys, these non-human primates, are vaccinated, and then they're allowed to build up their antibody and T cells for a while. And then once a week, this is a weekly challenge, they're given a bolus dose of the simian, which is the monkey version of the virus. And you have these quick studies that only take a few weeks to do because you're giving them massive doses of the virus. All your control group, by the 3rd time that they've had a bolus, are all infected. And then this is the vaccinated group. And this is the reason why we get up in the morning, because we think we have a really interesting vaccine and can't wait to figure out a way that we can come up with $20 million to pay for this next clinical trial. Very briefly, this is that cleft that I was explaining. This is what the Ebola virus looks like. And one of the things that Bob touched on was the host for these dreaded diseases. You know, we've quelled this first epidemic of Ebola, but Ebola had actually been tracked. It's been around a lot longer than 1976 back here in the beginning, but there have been roughly 28 outbreaks up until recently. And the reason why is because it's in host animals. It's either in monkeys, but primarily it's in fruit bats that inhabit that sub-Saharan area where there's a lot of other hemorrhagic diseases. And so this is what our data looks like when we use our Ebola vaccine. Remember, we're making these virus-like particles to stimulate antibody and T cell responses. These are our control groups. This is the vaccinated group. After they've had a chance to settle down after 2 vaccinations, this is time post-exposure in days. You can see how fast this works. So these animals are exposed in a BSL-4 type laboratory, and it only took about roughly 8 to 9 days for the 2 control groups to be fully infected, and we had 100% protection. Now, how long is it going to take us to get this vaccine out? We go from rodents, now we go to non-human primate models. We started our vaccinations this week. That's going to take a few months. It's going to take a year to actually make the vaccine itself. It takes that long to go through the process to make it, and then you start a phase 1 clinical trial. So when people say, why are these things so expensive? It's because the time and effort that it takes to get them out the door is horrendous. And then just very briefly in the immuno-oncology space, a lot of these are very easily treated using standard of care. either these cocktails or radiation treatments, but we're going to go after the pancreatic cancers, the lung cancers, et cetera. And we're actually looking for what's going to be the antigen we're looking for. It's called mucin. And that mucin is usually in these solid tumors. We're going to put that antigen into our vector. We're making that vector now. We're just in the early stages of that process. It's going to take us a few months to do that. And we're planning by spring to be able to get our first animal trials done so that we can use some animal models and see whether or not we actually produce those virus-like particles that I was telling you about before. And then quickly, I'm not even going to talk about Zika, other than the fact that it takes at least 18 months to get a vaccine out the door. And there is one company that has a head start on everybody else. They think they're going to be in human clinical trials by the end of this year. They're a competitor of ours, so I'm not going to mention their name. It's Inovio, by the way. They're actually a Pennsylvania company. And they hope to be in human clinicals, but it'll be 18 months before we get there. And then just two other targets that we're eventually going to go for. Hepatitis B, but this is for treatment. And there's hundreds of millions of people that are infected with hepatitis B globally. You can see them there. And there are preventive vaccines for hepatitis B, but there is no preventive or cure. There's no cure for it. So we want to do combination therapies for a cure for hepatitis B, but we have not started that project. And then the other one, which is a global disease, put these in here because Ruth wanted this to be a global discussion, and that is the prevalence of CMV, which we actually have here. Probably 50% of you have all come down with a CMV infection. It's not a big deal. It's not a big deal until someone happens to be pregnant and ready to deliver, and that transfers over to the baby that's exposed, and then there's all sorts of neurological side effects from a mom that's been CMV positive. So I'm going to leave it there. Hopefully we'll have some good discussions from you when we get to the panel. Thank you.
Hello, everybody. I am not an alum. I hope you'll forgive me. I think the universe is going to punish me for not being an alum because my slides are a little wonky. We can't get the full screen up, but she's fixing it for me. So we'll just adapt as we do. I first of all want to thank the organizers, because this is really a fantastic selection of topics going from these multiple diseases that we have in the world, and one of the number one ways that people die, whether you're young or old, or whether you're in an industrialized country or elsewhere, infectious diseases continue to be one of the greatest killers of all ages. And so we take that and say, what can we do about that? And you then think about vaccine development. And so we heard a great talk from Bob number 2 about vaccine development. And then as that vaccine gets developed, you have to get it out to all of us. And the way you do that then is you bring it to government agencies. And so for us in the United States, it's the Center for Disease Control. And the committee is the Advisory Committee on Immunization Practices. And that is a body of specialists that work on vaccines themselves, vaccine policy, public health. My world, coming from a children's hospital, they call me Practical Patsy at the CDC, because I'll say, now, how will we implement that into the immunization schedule? So I was fortunate enough to be the first nurse in the United States to be a voting member and be able to bring that kind of nursing perspective to that public policy and that vaccine decisions. And so I still am there. I'm not a voting member anymore. My 4-year term was up in 2008. But I represent the National Association of Nurse Practitioners and listen and give input into new vaccines that are coming or new schedules that are changing, et cetera. So it's been quite dynamic. Once that vaccine policy is made, then we get it out into the community. And that is really where the heavy lifting is how do all of you clinicians, nurses, providers, physicians actually know what that vaccine is? How is it's safe? How do you give it? How many doses? Where do you give it? Is it IM? Is it sub-Q? There's so much that has to happen in terms of implementing it. And I think sometimes I feel like that's where we sort of fall off a cliff, that we're really good at making policy, but in terms of implementing it, we have some work to do. So today what I'm going to do is talk a little bit about my experience as an infectious disease nurse practitioner for 27 years at Children's Minnesota. And arrow down is going to be my thing today. Okay, very good. I can do that. And so I'll bring you some stories from some of my patients and families in bringing vaccines to them and hearing some of the things that we've had to deal with in terms of the change with social media and how it doesn't really matter to some families what science and evidence says. They want to go to their favorite blog and follow what a mom at home in her jammies saying what she thinks you should do with your kid tomorrow at the doctor's appointment. And so we'll see a little bit of how that has impacted us. So we'll talk some about the vaccine successes, some of the climate around vaccine safety and how that has changed, some principles of communication, and then I'll leave you with some of my favorite websites. So here's my disclosures. I don't accept any honoraria for talks. This wonderful forum is donating to Children's Hospitals and Clinics of Minnesota, and they say thank you. I talked to you about my ACIP involvement, so I am not objective. I am strongly in favor of vaccines. So that is my full disclosure. My two daughters are fully immunized. They wished I worked at Nike or some other place because this is what they got from me, was lots of vaccines. My husband would not dream of skipping his flu shot, and my dog is up to date. So that's my disclosures for today. So I was asked to talk a little bit about, well, how do we know? What are the benefits of vaccines? And just a few little tidbits here. Vaccines have saved more lives than any other medical intervention, second to water and essentially sanitation. So just think about that. When you think about how amazing technologies we've had, open heart surgery and transplants and amazing medications that keep diabetics alive and insulin and asthmatics and all the things that we have had, there is nothing that has saved more lives than vaccines. And the World Health Organization has some really tremendous statistics on that. The scientific benefit of vaccines requires more rigor, more analysis, and more regulatory oversight than any other medication. I think Bob really kind of touched on that, of the multiple phases and testing and retesting that has to go on with vaccines. But in pediatrics, most of the medications we use in children have not been tested in children. We just test them in adults and we change the dose a little bit. And so I think vaccines are very, very highly regulated and go through lots of safety rigor. And you may hear about, there might be a vaccine side effect or something severe, or aren't vaccines dangerous or unsafe? And a severe side effect from immunization, a vaccine, is exceedingly rare. It just doesn't happen. In 27 years of taking care of children in my clinic at Children's Hospital, I can think of 2 patients that had to be admitted to the hospital after a vaccine because of a concern, and one was just a cellulitis. And the other one was a significant developmental change, an actual change in their behavior. That was this 1 in a million that we hear about that does happen, but side effects that are severe are very, very exceedingly rare. And just for a little bit of context, I thought I would just give you a history tidbit here. More Americans died of diseases than from combat in all the wars leading up to the 1918. So we didn't have vaccines. We didn't have antibiotics. We had war, but people weren't dying from war. They were dying from infectious diseases. And then after World War II, with vaccines and antibiotics, there were combat casualties. That's what's predominated ever since. Of course, you have to put in that balance, our weapons have changed quite a bit in those years too. So in the recent wars, more military individuals have died of suicide than of infectious diseases. So we vaccinate all of our military before they go out into the fields. And if you like the history of medicine, some of the interesting use of smallpox as a bioweapon, coming in and using smallpox to try to wipe out some of the enemy, and what George Washington said, no one's going out to fight until they get vaccinated. So there's some pretty interesting, do a paper on that if you want, that'll be good. All right, so now another question is, well, are vaccines safe? And as I said, the CDC says that about 1 in a million individuals will have an anaphylaxis. That is, they got wheezy or had hives or had to go to the emergency room because of a reaction to a vaccine. So it's very, very uncommon, 1 in a million, and very few of those anaphylaxis individuals die from it. And so when you look at, well, what do children die from? And you look at this global pie chart here, again, it's infectious diseases. You don't see vaccines in that pie chart. Children don't die from side effects from vaccines. They die from infectious diseases, which we are trying to eliminate. So you can see pneumonias and diarrhea and many of the things that we have developed vaccines over the years to try to prevent. Those are the things that cause children to die, not vaccines, despite what you may hear in social media, television, Facebook, etc. So the most common safety event with vaccines is fever, is local site reaction. So you may get some redness, some soreness. Well, you all have had your flu shot this year. I know you all have. Thank you for doing that. And you know how that is. Your muscle's a little bit sore. If you get some redness, some swelling, I say to my parents, that's actually, you're looking at a wonderful immune response. That is a good thing. Your white blood cells see an antigen. It rushes there. It takes it in. It makes all those B cells. It files it away. In case you breathe in an influenza, out that army comes, protects your child. They're good to go. So you try to make sure that they understand that local redness is really to be expected. It's not an adverse event. Systemic events like fever are really much less common with vaccines. And the differences of live vaccines or inactivated vaccines will give you a little bit different side effects. For example, our live vaccines give you a little mini course of the disease. And so you can't expect it to behave differently than the regular disease. It's a live vaccine, so you may get a live rash and a live fever. And I ask people to mark on their calendar 10 to 14 days after that vaccine, put the word rash on there. And then when your child develops a rash and it looks just like chickenpox right where they got the shot, they say, oh, that is one smart nurse practitioner. She told me that was going to happen. And so about 5% of people will get a vaccine-associated rash. For measles, it looks just like measles. It's not contagious. They can go to daycare. For varicella, those vesicles or those little water blisters are teeming with virus, and so they cannot go if they can't cover it. They have to kind of make sure they're not around any immunocompromised individuals or people at risk for severe chickenpox. So we do talk about those kind of normal side effects. I think our job as clinicians communicating is to be honest and to be evidence-based. And so if I said, I'm giving you your flu shot today, you are not going to get the flu. That is not correct. That would be overselling it. And so you need to say to people, I'm giving your flu vaccine. This is your best tool to prevent one of our most severe diseases. Last year, we didn't have a very good efficacy rate because we had a mismatch of what was in the vaccine and what came. This year, it's about 60%. So you have a 60% reduced chance of getting ill from influenza. If you don't get your flu vaccine, it's zero. You're not going to have much support there. So we do know that vaccines work. This is another question like, well, weren't these diseases going away even before vaccines came? Do we really need them? Do vaccines work? And this is a kiddo with chickenpox, and you can see the various stages from the crusted over to the water blisters to the red base that will develop. And that dramatic drop in chickenpox, 1995, I had a 5-year-old at the time, and I couldn't wait to get her vaccinated. Again, she was like, really, Mom, do I have to do this every time? Yes, you do. And the incidence of chickenpox dropped down dramatically. A lot of people will say, well, it's just an itchy rash, and you're, like for me, I'm from a big family, and so to have 5 days at home with my mom's attention and popsicles, that was actually not too bad. But for most, there are about 100 people a year in the pre-vaccine era who died from chickenpox, children, pregnant women, immunocompromised. And so it has severe potential for pneumonitis. You can get chickenpox in your lung, in your throat, in your brain. And we had a terrible story at Children's where it was a teenager getting ready to go to prom and just had terrible abdominal pain, went to a local hospital and they said, "You're constipated, take this," went back to that same hospital. "I just feel awful," went home, sent home again. Third time came to Children's and we didn't see rash. He didn't have rash, it was all internal, and he ended up going to our intensive care unit and dying. And this was 1996, so this was a year after the vaccine came out, and we realized on his autopsy that he had systemic varicella, chickenpox, and died of chickenpox. And so when people say, well, it's just a rash and I'd rather just get it naturally, you're risking something you don't need to risk, because the vaccine is safe, it's effective, and that's a tragedy that family could have prevented. And the dad looked in the camera and said, "Why didn't I know there was a vaccine for this?" And that's what I mean about we make a policy and then we don't do a great job of implementing it. We're slow in healthcare to implement, so we've got to pick that up. So you've heard a lot about measles, Disneyland, measles this last year, and burn this picture in your brain. How many of you are nursing students here? Okay, welcome to the profession. Very good. So burn this picture in your brain. You may never see it. I won't ask how many of you have seen it because that's kind of an age question, and I don't want to get in trouble with that. But this is, we refer to it as a bucket of rash poured over your head. So it starts on your face, goes down your face into your chest, and clears the same way. And this has been something that we've been seeing more and more because people are skipping the measles, mumps, rubella vaccine, and we can talk more about the reason why. I think you know there's no relationship between MMR and autism, but it got some traction and has scared a lot of parents in the world. We saw a case in 2011 in Minnesota, and I helped write this paper on an outbreak of measles in an under-vaccinated community. It was actually people who were in a homeless shelter. So if you're homeless, getting your MMR number 2 is not like top priority. You're wondering where your food is coming from. And so it really spread through that group. And so you can see the cases again of measles that have dropped down, and how when a vaccine is introduced, what happens to the incidence. So that tallest red bar was the year I was born, and 58, and then down to 1963 where the vaccine was introduced, and this really substantial drop. You see that with Haemophilus influenza B, you see it with measles, you saw it with chickenpox. Vaccines work. They've saved lots and lots of lives. But then you see this increase here. This is now taking us to the filter of 2014 and 2015, just last year, where in 2014, that line that's a little bit lighter colored, over 600 cases of measles. This is a vaccine preventable disease, and this is partly how I became a vaccine geek. Was in 1990, the United States had a major measles outbreak, and in Minnesota we had 440 cases, and 3 children died, and 2 of them died in my hospital that we took care of. It was a crisis, and I just could not understand why are we seeing this disease, a vaccine preventable disease. And that whole notion of needing to come in more than just 2 months, 4 months, 6 months, that you need vaccines all the time. Always ask when you go, you as a healthcare consumer, do I need any vaccines? Am I up to date? What else should I be getting? And really make sure that you're having that conversation. And here's the reason why. If we don't have that conversation thoroughly, we can have children that will be in a life-threatening situation. So this was one of our patients in 2011. He was one of our index case who had traveled internationally, went back to meet his grandparents in Kenya, and The mom did everything right. She took 4 kids under the age of 6 on a plane by herself to Kenya. She needed a medal just for that alone. But she brought them all to the International Travel Clinic and wanted them vaccinated. And this little guy had just fallen asleep. And she said, you know, he's only 9 months, and aren't you supposed to get it at 12 months? And the clinician said, yes, but you're international traveling, which means you give it earlier. And that's a board question, nursing students. And so she said, well, he just fell asleep. I'll do it when I get back. And she calls that her fateful decision. That at that moment, the clinician pushed and pushed, and she said no. And so they went on the trip. The baby was exposed to measles, was incubating measles as they came back, had a fever, and went right to our ICU and was on a ventilator. Now this mom, she said, I refused the vaccine because he was sleeping, and now all I want him to do is wake up. And I took this with my cell phone, and she said, take this picture, show it to students, show it to parents. I want them to know how awful this disease can be. And she said, are you getting the ventilator? Are you getting the tubes and the monitors? Now stand back, get all that. I said, yeah, I think I got it. You know, so he did survive, and he did okay. He was on a ventilator for a long time, and in our hospital for almost a month. And her message really is, just follow the schedule. You know, just listen to your clinician, work with them, and not try to kind of change things. So I want to just say that this hesitancy is not new. The vaccine hesitancy, look at this from Benjamin Franklin, and I also kind of wish we still talked like this. 1788 autobiography. He says, in 1736, I lost one of my sons, Frankie, a fine boy of 4 years old, by the smallpox. Taken in the common way, I long regretted bitterly, and still regret, that I had not given it to him by inoculation. This I mention for the sake of parents who omit that operation on the supposition that they should never forgive themselves if that child were to die under it. My example showing that the regret may be the same either way, and that therefore the safer be chosen. Isn't that amazing? That is 1788, and we are still dealing with this same kind of parental sort of angst around, should I vaccinate, should I not vaccinate? And this is dealing with one of our very first vaccines, smallpox. And here was a parent fast forwarding to 2012 having that same angst. This was a patient I took care of, and her daughter was 4 years old. And she said, all I heard about vaccines were that they caused autism. I didn't want that, so I didn't vaccinate. If I knew this could happen, I would never have skipped vaccines. I wish someone would have told me instead of saying okay when I refused the HIV vaccine. So an ambulance went to her house to get the grandpa who was having chest pain, and the EMTs looked over at her and said, what is this 4-year-old doing? Drooling, wide-eyed, gaping, air hungry. And the mom said, well, she's been breathing funny like that the last couple of days. And they recognized that she was in significant trouble, brought her out to the ambulance, and she had a full respiratory arrest in the ambulance. She was up 14 times. They tried to intubate her, and finally came to our intensive care, and an anesthesiologist finally was able to intubate her. She did survive too, but the mom had this whole new view of vaccines. She's like, why would anyone skip vaccines? And she said, I am not leaving this intensive care unit until you give me everything you have. And so they called me, and they're like, we don't know how to do this. You know, can you come and help us give all these vaccines? So I said, sure. But it's quite a story. And so this still abounds. Lots and lots of different myths. You hear this on Facebook and social media that, you know, don't get a flu shot, it gives you the flu. That is not possible. It's inactivated. Vaccines can cause different diseases. Babies are too weak. I mean, babies are weak. They can't talk, they can't walk, they can't roll over, they can't feed themselves. But I'll tell you what is not weak: their immune system. If their immune system was weak, they would not survive in the world. They wouldn't survive the birth process. So our NICU, when those babies hit their 2 months of age, adjusted age, we start vaccinating them in the ICU. They're plenty capable. So in closing, I just want to say, how do we talk to families about this then when we have these myths and have these conflicts? Sometimes talking about the myths, I think, perpetuates the myth, so you have to be careful not to continue to talk about autism and MMR, because that's what sticks in people's heads. But I think we approach it in a very presumptive versus participatory way. Presumptive is, I'm going to presume you are here to see me to get shots, to get vaccines, to keep your child healthy. You just are like, we're on the same page on this. You presume it. And so you'll say, it's time to start our 1-year-old vaccines. We're going to do 2 live vaccines, MMR and chickenpox. The literature says parents will accept this 75% of the time the child will get vaccinated, as opposed to the participatory, and this was through video, watching clinicians and how they communicated through video studies. How do you feel about vaccination? Well, you know, feeling, this is not a belief system, this is a science, but parents only accepted it 4% of the time and rejected it 83% of the time. So what you have to do is show that you care and that you're competent. You have to know what you're doing. That's why you're here at this wonderful institution. And you have to show that you care, and that's why you're in this business of healthcare. That's when people will trust you and you will have a better conversation. And then you use that caring and that competency. You use your credibility to be clear, to have that chemistry. You see those patients back again and again. You collaborate with them. Like, tell me what it is you're afraid of with vaccines. I really want to understand where you're coming from. You listen first. Make sure you understand where they're coming from. And then this spectrum of refusal, I think people, when you look at the media, they'll be like, here's this parent who doesn't vaccinate, and this is how parents are. You get this sense that no parents are vaccinating. And in fact, 70 to 90% of American parents vaccinate their children on time. And another, that middle column, that 10 to 30% they're just hesitant. They're a little worried. They read this thing and their sister-in-law told them this, and they're just nervous about it. That is the middle, that middle population is what we're worried about, is growing. That is growing. The hesitant, the people that want to kind of cherry pick their schedule, spread it out, do their own thing. I'm not going to follow the CDC recommendations. I don't need science. I'm going to kind of do my own thing. I like natural. We'll just get chickenpox and see what happens. There's no need to kind of risk your child's life for that. And thankfully, only about 1% of parents are truly no vaccines, completely anti-vaccine. And there's a story that's circulating now about a family in Alberta whose child died of Hib meningitis because they were completely naturalists. Even when the child was sick, he couldn't sit in his car seat to go get care. They had to lay him down in the back of the car because he had meningitis so bad. That's a rare family. So last, we have to remember that it's not just us vaccinating ourselves or our children, that we have to think of this as public health. We have to think of it in terms of global health. All these vaccines, all these diseases, measles, chickenpox, if you care about your community, you have to care about the rest of the world, because we are an international society. And this little guy in that measles case that I told you about, on the child on the ventilator, they shared airspace in our emergency department. This little guy, Ben, had leukemia. So they had to wait they had to come in and get immune globulin prophylaxis and wait 21 days to see if he was going to get measles or not. And this mother said that 21 days was harder than getting the leukemia diagnosis. And so when we care about our children and vaccinate them, we are caring about the Bens of the world. We're caring about those who have immune deficiency or on chemotherapy or have other problems that they themselves cannot be vaccinated. So his story was in the USA Today, and this mom is just now one of our greatest vaccine advocates in the country. She's just doing a wonderful job sharing their story. So if we ignore the hesitancy, if we ignore and just sort of say, well, whatever, if you don't want to do it today, it's okay. If you get tired, it's 4 o'clock on Friday, you want to go home, you have to make sure you just think about, if we ignore this hesitancy, it will impact our community and diseases will come back. So I'm going to leave you with my favorite website. It's really easy to remember for vaccine information is immunize.org. Immunize.org has everything for parents and other individuals. So thank you very much for having me.
Well, with HIV, it's a preventive vaccine, and so what we would see happening would be the primary people to be immunized in this country would be the gay population, healthcare workers, military, and eventually it would have to be in the whole adolescent population, like the papillomavirus vaccines.
Patsy, you were amazing.
Oh.
You literally gave me goosebumps. You were so inspiring. Is that weird? I don't know. But I have been in situations where a parent has refused vaccinations. Was in my OB experience. It was for hepatitis B, and I don't think anyone knew how to respond. Like you touched upon, I liked how you said, "Okay, this is what we're doing," instead of the like, "How do you feel about this?" Because that just, as evidence shows, isn't a good. It doesn't show good outcomes. What like research has shown is the best response for that first denial of I don't feel comfortable with this or I don't want to do this or what is, I guess I'm asking the best research and response.
Sure. A couple of resources that just to give you more to read about, so that immunize.org has some of these conversations, like what do you say if, and sort of can walk you through. The American Academy of Pediatrics does as well. The Center for Disease Control website has a lot of those sort of, you can walk through some of these scenarios. I really think in a scenario that you just talked about is, I just put my pen down, I put my paper down, I get off the computer, and I just turn towards them and look at them and make sure they understand you have all of my attention. And I care about you and I care about your child. Tell me more about that. And you leave it open-ended and you let them just talk. So what is it about hepatitis B that you're concerned about? And is there someone in your family that had that? Is there something you read, or where did you get that information? Let's talk more about it. And then you say, okay, let me tell you about my experience with hepatitis B. And you can talk about clinical experiences, and you'll pile those up as you get old like me, But when you're sharing with them that this is an anti-cancer vaccine. So for our lifetimes, we have people like Bob here trying to work on vaccines that prevent cancer, prevent things, and now we have it and we don't want to use it. And then you can pull up data and show, and sometimes data doesn't work, but you show the safety profile. Of all vaccines, hepatitis B has the lowest number of reports on adverse events. It's an extremely safe vaccine. And then I say, I gave it to my babies at this age, and I really don't want anything less for my patient, your child. So you mentioned inspiration. It is, you have to do that. You have to be inspiring as a clinician, as someone who's trying to explain to people the science, and as well as the stories. I think it's an important combination.
Hi, my question is also for Patsy. I'm just wondering, is it difficult seeing, your patients have these preventable diseases just because they didn't get their vaccines, because their parents didn't vaccinate them? How do you kind of remain unbiased to that situation? Well,
You have your closed door places. So we have a team that works really, really hard at our Children's Immunization Project team, and we, as all of our clinicians, we have 30 sites and hundreds of clinicians that vaccinate every day. And there, you do get tired. You do get like, I'm gonna hit my head against the wall. Like, why wouldn't you vaccinate? But you have to remember, like the patient that you see on Friday at 4 when you are tired should get the same high quality care as that patient you saw on Monday at 8 in the clinic. And you can't bring your own personal baggage. You have to kind of, again, be therapeutic, talk through, have good communication skills. And then when you go with your team and you close the door, you go to happy hour, that's where it all comes out. So.
I'm Sister Jacqueline. I want to ask something to Dr. Robert. I was impressed by your presentation, how you developed the vaccines, and I'm just wondering, I come from Africa where infectious disease is a major problem, and we have had cases of sometimes we have our governments who sponsor the childhood immunizations, but many of other vaccines we are not able to afford because of the cost. They are very expensive. and I was happy to see the process that you take in developing those vaccines. Is there a way that you can be able not to put the cost on other vaccines so that many people can be able to afford, especially those from less limited resources? Thank you.
Yeah, that's a good question because cost isn't so much a factor in this country where we have insurance to cover things, but in the developing world, it's a significant issue. And so what we do as you know, from a manufacturing standpoint is we explore different ways of trying to get that cost down. And one of the ways is these manufacturing methods that right now are vaccines made in embryonated chicken eggs, which as you can imagine, you need hundreds of thousands of chicken eggs to grow up this vaccine. You have to use robots to get that process done. It gets quite expensive. And so now they're developing continuous cell lines like bioreactors so that you're fermenting these vaccines continuously over time. And that probably has maybe anywhere from 10 to 50-fold effect on driving the cost of a vaccine down. Those technologies in their own right, licensing for those technologies is rather expensive, but overall, that's the only way we're going to get the vaccine cost down. So there are ways of making it, the actual manufacturing process.
I have a question. You were saying that social media has really influenced negatively some parents' decisions. Have you ever thought of kind of using fire with fire and using social media to get ahead of it?
Yes, for sure. So I was forced into going on Twitter, and then I had to go to remedial Twitter class because I didn't do it very well. My tweets were too long. I know you're shocked at that, but we definitely, hospitals, children's hospitals across the country are very much realizing, it's time to jump in and be part of the conversation and have this strong and science-based conversation using Twitter, using Facebook, blogs. I used to think blogs were just, where crabby people went and, shouted in the night. And blogs can be extremely, extremely helpful to follow. And so I think most institutions, I really have totally turned my view around about the power of Twitter and getting a voice out. And I'll tweet about all you in a little bit here.